HSE data are important because HSE includes measurements. It's a health examination survey, and it represents the whole population. We've published a couple of papers showing how HSE data are used by government to identify issues, to develop strategies, to set targets, to monitor and evaluate policies, and to review them. Information about obesity is probably the most commonly used information from the HSE. The data from the interviewers' measurements are really important because when you ask people, they tend to underestimate their weight and overestimate their height. That means that BMI calculated from self-reported information substantially underestimates how many people are obese. HSE has helped researchers and policymakers show how common obesity is, who is more likely to be obese, and what the inequalities are by age, gender or income. HSE data have been used a lot to model what might happen in the future, to develop strategies and clinical guidance, and evaluate the success of obesity strategies. For example, the government's childhood obesity plan began with the statement that a third of children aged 2 to 15 are overweight or obese, based on the HSE 2014 report. Being a health examination survey, we can use HSE to detect how common undiagnosed disease is. Each year, the nurses measure blood pressure and ask about medicine use. We use this information to see how common hypertension or high blood pressure is and whether it's being treated well enough. Most participants don't have hypertension, but that proportion falls markedly in older age groups. We can identify 3 groups of people with hypertension: untreated, treated but uncontrolled, and controlled, where they are taking medicines to lower their blood pressure and the BP is less than 140/90. As the chart shows, from 2003 to 2011, the proportion of people with hypertension, shown in grey, didn't change overall. What did change was that the percentage with untreated hypertension, in purple, fell a lot, and the percentage with controlled hypertension, shown in green, almost doubled. We have used blood test results to look at diabetes. Glycated hemoglobin tells us the average level of sugar in the blood over the past 2 to 3 months. If an HSE participant answered no to the interviewer's question about having doctor-diagnosed diabetes, but has a blood test result that shows diabetes, that person has undiagnosed diabetes. We knew that levels of reported diabetes were increasing, but nobody knew if this was because diabetes is becoming more common, which is likely given the increase in obesity, or if more of the cases were being diagnosed. We showed that both are true, both diagnosed diabetes, shown in purple, and undiagnosed diabetes, in grey, have increased.
A main aim of the Health Survey for England is to examine differences between groups, to explore how factors like sex or age or the place where you live can affect your health. This allows us to understand health inequalities, a major concern in recent years in Britain and beyond. The impact of such differences can't be overestimated. For example, comparing areas within England in 2015, men in the least deprived tenth had an average life expectancy of 83 years, compared to 74 years in the most deprived areas. That's a difference of 9 years. For women, the difference was 7 years, between 86 years in the least deprived areas compared to 79 in the most deprived areas. That's not all. Healthy life expectancy, the period you can expect to live in good or very good health, differed between the least and most deprived areas by 19 years for both men and women. In the most deprived areas, healthy life expectancy is around 52 years, which means for those men and women, a substantial portion will not just have shorter lives, but they will spend about a third of their lifetimes in poor health. The Health Survey for England is very powerful in understanding the causes and impacts of health inequalities, because it pulls together data about different aspects of people's lives. First, we collect a lot of information about people themselves, including their age, sex, ethnicity, employment and income, and the characteristics of the areas where they live. We ask about their health-related habits, such as smoking, drinking alcohol, exercise and diet. From this, we can see that people in the most deprived areas tend to live less healthy lives. For example, they are much more likely than those in the least deprived areas to smoke or to be physically inactive, are much less likely to eat their 5-a-day portions of fruit and veg or to take the recommended amounts of exercise. In contrast, it's people in the least deprived areas who are most likely to drink alcohol and most likely to drink at risky levels. The data collected by interviewers and nurses also gives a range of information about people's experience of ill health, both through questions and also via the measurements and samples we collect. This helps us understand how people in the most deprived areas have a greater likelihood of health problems across the spectrum. For example, the 2016 HSE report identified people in those areas as more likely to have poor mental health, to have doctor-diagnosed liver disease, and, for women but not men, to be overweight or obese. In addition, they were more likely to be taking 5 or more prescribed medicines, and older people were more likely to have unmet needs for social care. These examples look at inequalities based on the areas where people live. The HSE also allows us to look at inequalities by other characteristics, for example, income or ethnicity, where inequalities are at least as great.
Using HSE data to monitor trends in the nation's health was a key reason for starting the survey in the early 1990s. This gives the HSE a unique and a highly valued place among government surveys. It has public health impact through being used by central governments to monitor trends in key health targets such as 5 a day and meeting the UK guidelines for physical activity. It can be used to evaluate whether government policies or public health campaigns have been effective in changing lifestyles or behaviours. The HSE data is also used to hold governments to account. The evidence from the HSE clearly shows that inequalities in health have not changed or have even widened over the last 2 decades. HSE trend data has an impact by being high quality, visible and widely used. Visual displays of HSE trend data can be found in our annual reports, on the internet and in government reports. As you know, HSE data appears often in the media, whether it is good news, fewer children are now smoking, or whether it is bad news, levels of obesity have remained the same over the last decade. As some of you will know, participants are asked a number of statements about their health over the past few weeks. We put their responses together to identify persons with probable mental ill health. The HSE data shows a gradual increase in the percentage of persons with probable mental ill health, rising from 15% in 2012 to 19% in 2016. The BBC, at the time of the publication of our report, blamed this increase on everything from austerity to social media. But there is some good news. By the turn of the century, over a quarter of adults smoked cigarettes. Now, it is down to fewer than 1 in 5. The decline in the number of adults drinking more than 14 units of alcohol a week has been more gradual, though men are twice as likely as women to do so. A leading academic based at UCL wrote in an article for the British Medical Journal that evidence informs the debate. It tells us whether things are going in the right direction and to what extent. Evidence therefore clearly matters, and through the efforts of a committed team, the HSE has been providing high quality evidence for over 25 years, and it is still going strong today.